Good evening, and welcome to tonight's webinar, Palliative Care, Myths and Facts, brought to you in part by Lilly Oncology. My name is Kevin Bergerson, and I am the Programs Manager for the Colon Cancer Alliance. And on behalf of the Certified Patient and Family Support Navigators and the entire Colon Cancer Alliance team, I want to thank you for joining us this evening. Tonight's webinar will discuss the myths and realities of palliative care and how it can assist patient suffering, improve quality of life, and lend understanding to treatment options and achieve the optimal care outcomes that all patients want. This webinar is being recorded, and all registrants and attendees will receive a link tomorrow evening to where we have posted the webinar recording online. I'd like to remind everyone that neither the Colon Cancer Alliance nor our presenter are giving medical advice, and no doctor-patient relationship is intended or established. You should always seek in-person medical advice and make medical decisions together with your clinician team. At this time, it is my privilege to introduce Dr. Manouchka Joseph, Medical Director of Palliative Medicine at Banner Desert Medical Center in Mesa, Arizona. Dr. Joseph's passion helps families get through crucial points of their health care by delivering compassionate, patient-centered care that addresses their emotional, social, and medical needs. Dr. Joseph holds an appointment as Clinical Assistant Professor for University of Arizona, where she facilitates education for nurse practitioners and fellows interested in palliative medicine. Dr. Joseph is also co-lead for the Palliative Care Clinical Consensus Group, identifying opportunities for improving care-based best practices within the palliative medicine system. Prior to coming to Banner, Dr. Joseph facilitated palliative care at the Phoebe Putney Memorial Hospital in Albany, Georgia, where she received the Phoebe Putney Memorial Hospital Caring Hands Award. She is also a recipient of the Outstanding Palliative Care Award by the Donor Network of Arizona for 2015, and most recently, in 2016, the Colon Cancer Alliance was proud and honored to have Dr. Joseph present at our Metastatic Colorectal Cancer Symposium, where she received glowing reviews. And with that, Dr. Joseph, welcome. I'm going to turn it over to you, and you're up and ready to go.
Hi. Excuse me. Good afternoon. It's actually afternoon over here. It's 4 o'clock, and I know it's evening on the East Coast. So my name is Manouchka Joseph, and thank you, Kevin, for the introduction. I am a palliative care physician here at Banner Desert Medical Center, and this afternoon I am presenting to you palliative care myths and facts. The objective of this presentation, I would like to go over my objectives with you so that you understand what's going to be discussed this afternoon. We want to review the vision for palliative care, review the conceptual model for palliative care, see how we can navigate medical decisions in cancer care, review the importance of matching treatment plan to quality of life goals. The main important thing in palliative care is to define the scope of practice, because often, like we mentioned before, palliative care means hospice, means no more aggressive treatment for either the patient or some of the providers. So it's important, especially in my practice, when I see patients, after I say my name, I usually like to define what my scope of practice is. Palliative care is specialized medical care for people with serious illness. We say serious illness because we not only see cancer patients, we see patients with heart failure, lung disease, end-stage renal disease. These are all serious illnesses, and we don't want to pinpoint by diagnosis because we can help patients with different comorbidities, different serious life-threatening illness. We provide relief from symptoms, so we are known to provide great pain management, any type of symptoms that may cause discomfort or impair quality of life, delirium, constipation. So we are experts in relieving patients from symptoms that make them uncomfortable. We also, our main goal is to improve your quality of life, because we know when patients are affected by a serious illness, first of all, it's not comfortable, it's stressful. So we want to make sure as the patient is undergoing care and treatment that they have the best quality of life. And we'll talk a little bit about what does quality of life mean, why is it important. It's provided usually palliative care by an interdisciplinary team that works with the primary medical team to provide an extra layer of support. So we don't work independently. We really are a layer of support to your specialists who are occupying your primary disease, treating and trying to cure the disease. And we provide that extra layer of support. We don't work alone. It's interdisciplinary because we are not only doctors, we have nurses, social workers, pharmacists, and other specialists that we can bring in as a team to really support you, because we know when we're affected by serious illness, it's a stressful situation where different aspects of your life is affected, including the social, emotional, spiritual aspect. Chaplains are also part of our team and very important in palliative care. It is appropriate at any age, so we do have pediatric palliative care as well, and it's also appropriate at any stage of the disease. That means that palliative care, you could be diagnosed, for example, with metastatic disease, and at the time of diagnosis, when they're presenting the diagnosis to you, you may have a palliative care provider in the room to really go over what's going on and provide support and understanding. And then the most important thing, and that will answer the big question, palliative care can be provided along with curative treatment. So if you want to have access to palliative care, you don't have to stop treatment. You don't have to forego treatment to receive palliative care. It can be provided along with curative treatment such as chemotherapy, radiation therapy, clinical trials. So we're here to really support you throughout the disease process. So hospice palliative care, what is the difference? Americans usually confuse hospice care, which precludes aggressive medical treatment and usually requires a prognosis of 6 months or less. So patients who go on hospice care, what Medicare regulation asks is if that patient lets the course of the disease continue on its own without treatment, how likely we think that the patient would die in 6 months. So that patient, usually when they go on hospice care, it doesn't mean that they will pass away within a week or a day. Some patients are on hospice for a long time, but they do not want curative measures or aggressive measures, or they are no longer a candidate for curative aggressive measures, and they want supportive treatment, comfort care. This is hospice care. The difference is that the palliative care team can be providing pain relief, psychological and spiritual support, even as the patient or the physician, the medical specialist, is aggressively trying to cure or treat the disease. So this is the difference. So some people go from palliative care as they're getting support, getting curative disease, and when either chemo is not indicated or it's not working, or the patient decides on their own that they don't want to go through any more treatment, then palliative care can transition you into hospice for more supportive comfort care. This graph, we really like this graph very much. I'm a very visual person, so once I saw that graph, it all made sense to me. So in this graph here, it really shows you the difference between palliative care and hospice. In red, this is the treatment aggressive measures portion. In light yellow here, this is palliative care. And the darker yellow is hospice. And that black line here is when a patient actually dies. And you see the care doesn't stop after a patient dies because the whole family needs support for bereavement. So the care continues to hospice services, to hospice benefit for bereavement care. So before we get to hospice, before we get to the dying situation, you see how long the patient can receive palliative care. This is the presentation here. As I said, as you're being diagnosed with a serious illness, palliative care may be involved, not the primary focus of the disease or the treatment plan, but as an extra layer of support. And the aggressive measures, so for example, in cancer, your oncologist, all that really will be the main part of your treatment plan or the main providers that you will see. But as the disease progresses, either with recurrence, either with progression of disease, and treatment options, sometimes they become thinner and thinner, and palliative care will occupy a bigger portion of your care as treatment options are getting fewer and fewer. And then it's only when the doctors feel that if you were to not continue treatment or you're not a candidate anymore, it's only then that hospice comes in at the last 6 months of life. And what happens, even though the patient is on hospice and we say it's very likely that the patient will pass away during the 6 months, if it's not time and the patient continues to have quality of life and live, hospice can renew the certifying period, and some patients are on hospice for more than 6 months. This is data from the National Palliative Care Report released by the CAPC. So this is the data from the CAPC website. I'm sorry. Oh, sorry, I think I'm pressing too many buttons at a time, but bear with me. This is from the CAPC website, and what they did is that in 2015, 2013, they decided to really have a big study and assess how many palliative care programs, how well the palliative care programs are functioning in the nation. And what they decided to do, depending on how well they're doing or how many programs they have in each state, they would give them the grades. Grade A, B, C, D, just like when you were in school. So surveys were sent out to all facilities, hospitals, home base. They sent out all these surveys so that we can fill out. So this is the most recent data. It comes out actually every 2 years about how much palliative care or how great palliative care is in certain states. So blue being A, so the states in dark blue here are the states that have the best palliative care program or more palliative care program in the nation. B is a yellow, so these states here are yellow, so they scored a B. They do have palliative care, but not many programs of palliative care. And then C is green, and then the orange color here is really states that don't have a lot of palliative care program and are good quality palliative care program. And it shows you there's a disparity depending on where you are, if you will have access to palliative care or not, and which is a big problem. We want everybody to have the same type of care or access to the same quality care, including palliative care all around the nation. There is still work to be done, but in 2015 our numbers were much better than the report we had back in 2013. And we can see here, I'm in Arizona, so we scored B. And then if you go here, Vermont, Massachusetts, they scored a blue, which is an A. This is another report also from CAPC, which is the Center for the Advancement of Palliative Care. It's a report card, and in this graph, what it compared is which institution have more palliative care involvement or services or program. And what they saw is that the non-for-profit hospitals were more inclined to have palliative care, or they were in more favor of having palliative care programs, whereas there is work to be done with the for-profit hospitals to have better palliative care programs and more patients can have access to palliative care. In 2010, actually, that's the year that I started fellowship in palliative care. There was a great study that came out of the New England Journal of Medicine, where in Massachusetts they had a study that studied patients that had metastatic lung cancer. And what they did is that they studied the care and the patients over time, and they had two groups. One group was patients with metastatic lung disease that had standard of care without palliative care, and at that time that was 2010, and they had another group that had palliative care from the beginning at diagnosis. And what they saw actually is that patient not only had the patients who had palliative care at the beginning at diagnosis and all through treatment, they had a lower incidence of depression, lower incidence of anxiety, and also what they found out is that these patients lived longer than the patient who did not have palliative care at presentation. So since that came out, that study came out in the New England Journal of Medicine, then it really encouraged people to support palliative care programs. And now most, not to say all, the cancer centers in the nations have supportive care centers which are palliative care program, because we want to make sure that not only the quality of life is better, but there is benefit in even longevity in having palliative care involved in the care. Now, the question palliative care here, when we meet as a team, the focus is really on helping people have the best quality of life and also make the best medical decision that would match the best quality of life that they would like. And we can all agree, and we say it over and over again as a team, that everybody's quality of life is different. The reason why I have this picture here is this is my quality of life. I love to hike, I love nature, I love outdoors, and I know that my quality of life, it will be very affected if I cannot do the things that I like to do. And I have to decide when I'm making medical decisions, how is it going to affect my life and my quality of life. So palliative care helps you achieve these quality of life goals, and it helps you from the beginning. Help you, identify the doctor that's best for you. Have an open discussion. We want you to look up the doctor's specialty, compare it to your diagnosis, help you ask the pertinent questions. Because when we sit down with you and have a goals of care discussion, we put your wishes, we put your goals together, and we help you when you meet with your oncologist, when you meet with your specialist, to ask pertinent questions as far as the treatment, the options, and how they will affect your life. See how the doctor makes you feel. Does the doctor embrace your philosophies and your way of life? Does he listen to you? Does he have good bedside manners? So you can go to see your doctors and we report to us. You tell us that you have a discussion with us, and we tell you how do you feel about the doctor and help you process, what is being said and how you feel. So we make sure it's a good match and we help you decide. Also, after seeing the doctor, you may have questions. Were you informed well? Did you understand what he said? Are you ready for treatment? These are the questions you ask yourself, and the team can help you with these answers, or even act as a bridge and coordinate a care conference. Care conferences are between patients, specialists, social workers, chaplain, so that we can really address your concern and also side effects. And that's where we come in, because the treatment can be a great treatment, but it comes with a lot of symptoms. And as palliative care providers, symptoms are really the medical portion, what we handle with the patient. And we may be able to not only predict what kind of side effects you will have, but also to treat them as well. And then palliative care helps you identify where you are in the disease process. So it's a very big question to ask yourself, and we're here to help, because everybody is diagnosed at different time and at different stages of their disease. Some people are at stage 1, some people are at stage 4. So palliative care is there to really help you identify what does that mean to be a stage 1 for a particular type of cancer. What does that mean to be a stage 4? What are the prognosis? What to look forward to? What are the treatment options? How will the treatment affect my life and those that I love? And what are my values and beliefs, and how that treatment is going to affect that? For example, if you are a Jehovah's Witness, for example, and you have concerns about blood transfusion, so then we help you with looking at the medication, which one would have more propensity to cause you to have anemia, and you would need things like that. So palliative, you will need a transfusion. So palliative care will help bring all these factors in the discussion, so that you can bring the values and your beliefs and match that to the treatment plan. And also always assess what your support system. Patients who have a good support system usually do much better with treatment. So we help you assess your support system. If your support system is not enough, we try to find resources out in the community to see if we can help you with support and help you with your treatment and have a good assessment, because you may at diagnosis be very functional yourself, but as the treatment or the disease progress, you start having issues with functional status, and that's where the support is really needed. Shared medical decision is very important, and that's what palliative care wants to continue to focus on. We want you to live in this new era of medicine where we practice what we call patient-centered care. It's the concept of shared medical decisions. In the old days, the doctors used to know all the information in the books. We still do, but the difference is we don't tell you what to do anymore. We want you not on the other side of the table. We want you at the table, and we discuss what is good and what is not good, what is acceptable and what is not acceptable to you. So we call that a shared decision-making process, which is a collaborative process that allows patients and their providers to make healthcare decisions together. It takes into account the best clinical evidence available, which is what the doctor is here to present to you, but as well as put your values and preference at the table as well, and we decide, okay, this treatment may be the best for you, but because of this and these values, you may not be happy with the outcomes, or your quality of life will be affected by that, and ask you, how do you feel about that option? So it is a world, it is a new era of shared medical decision in patient-centered care. Quality of life, like we said initially, quality of life is very personal. If somebody doesn't like hiking or outdoors like me and is more of a TV person, then I cannot compare my quality of life or what I want out of the treatment with his quality of life. And there's a general definition of what is quality of life from the World Health Organization, which defines quality of life as an individual's perception of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. That quality of life may be affected by their physical health, psychological state, personal beliefs, social relationship, and also their relationship with their environment. So quality of life is very much personal, but a lot can affect your quality of life. If you have a cold, or if you're not able to move, or if you have pain, then your quality of life is not at its best. And palliative care is here to make sure that this is optimal with psychological support, with spiritual support, and also help with social relationship. And that's why we work as an interdisciplinary team so that we can address all this. Quality of life considerations. Quality of life can be different things depending on the individual. It can be something that's considered by the individual as a property. I own my quality of life. It can be something considered philosophical as a goal of care. So I am having this right now so that 6 months later I am able to live this type of quality of life. It can be a social situation. For example, I need to work as much as possible. I need to continue working even while I'm on treatment because that is the social situation. I've always valued my work or being a worker. So that can be a situation, or it can be the moral worth of life. Some people are very pro-life. Life is precious, so as long as I'm living, as long as there's air, as long as I'm breathing, that's worth it. Life is good. That's a quality of life that's acceptable to me. And also what palliative care, different level that palliative care will help you, and that's very important, is advanced care planning. We want to have this in place as soon as possible, as early as possible. And we really encourage, even if you're not diagnosed with a serious illness, everybody should have this paperwork. I do, and I'm relatively young, but it is planning, and this is more of a process than an event. The reason why I'm saying that is that it's better to do this advanced care planning when you're relatively healthy, when your mind is clear. A lot of people think doing an advanced care planning means that you're preparing to die very soon. It's not that. You are planning. We do big planifications when we're having babies, when we're getting married, but the end, we are sure that everything comes to an end, life comes to an end. We need to prepare that as well, at least so that people know your wishes if something were to happen to you. It's an event. It's when you do it when there's a crisis, and a lot of time when there's a crisis, you're not thinking straight, and sometimes the decisions are not the best. What is advanced care planning? It's a process of planning for future medical care. It takes in consideration your values and goals. We explore that, and it is documented on a piece of paper. Also, in the advanced care planning paperwork, what is important to have, and that will be in that packet, is a proxy decision maker. It's what we call a medical power of attorney in certain areas of the country, but this is the person that when you're not able to make decisions anymore, that person will make decisions for you. And it's important that you choose that person not because that's the closest person to you, but because that's somebody that you trust, that in times of distress that they will know your wishes and they will stand up and do what you want, even if they're not comfortable with that. That means when you designate somebody to be your proxy, you need to have a conversation with them about your wishes. It's also trust building. You don't want uncertainty when there is a crisis or at the end of life. So you want to make sure that your children, your husband, that everybody knows that they heard it from you, that these are your wishes and this is how you want things to occur. A lot of time I see people that did not have an advanced care planning or discussions with their family, and a major event happens, and the family is confused because they never ask these questions and they don't know what to do. So when you have an advanced care planning and you do it in a structured way, then that uncertainty is definitely reduced. It helps to avoid confusion and conflict. It also permits peace of mind. And when I say trust structured discussion, it's not at Thanksgiving dinner when the children are going back home and you say, by the way, I do not want certain things. I'll see you tomorrow. This is something that you really need to sit down with them and go over, do what we call a little bit of teach back, and so that we all understand what your wishes are, what quality of life means to you, and how you want them to make decisions for you, whoever that medical power of attorney is. And it really does give peace of mind. 6 steps to successful advanced care planning. First of all, introduce the topic. So and so, who is your power of attorney? You will really say, well, I am about to do my advanced care planning. I intend to designate you as my power of attorney, and you introduce the topic. You engage in structured discussion. We just talked about it. You document your preferences. And then most importantly, if you had an advanced care planning that was done 6 years ago, 2 years ago, it could be last week, and you have a change of mind and you want to change something, it's so important that regularly you review and update your advanced care planning. Reviewing maybe, yes, I agree with what I've decided last year or 5 years ago, and or update may be that, oh no, 5 years ago I was feeling better, things were looking better for me, now I need to update it and have different wishes. So always remember, if you put that in writing, it's not written in stone, it can always be reviewed later, and also apply directive when need arises, and revisit, it's always okay. Now, you have to know yourself. This is my picture here, different than the picture you saw. So you have to know who you are, because these treatments, they really affect your day-to-day life, and there are things you may want to do, and there are things you don't want to do. There are things that you may want to consider on hold because you're early in the phase of treatment, but there are things you may want to not hold on if you know that you're very advanced in your disease process. I am also a traveler, so I may want to do a lot of things and have to hold on that if my treatment is going to ask me to be home more, to see doctors, or even to be hospitalized. So when you're talking to your doctor about what is treatment, what is it going to look like, you have to know yourself, plans and all that, so that you can schedule and maintain your quality of life. Ask yourself, are you active? Is that treatment going to slow me down, or will it let me do the things that I want to do, like going out, exercising, and how much of that is important to me? And also, is that temporary, or is that a new baseline for me? So ask yourself these questions. So these questions are things that I ask myself. I take them as an example of how I would process information. Are you a mother or a father? Are you a single mother or a single father? Because if you're a mother or father, or if you have a partner or not have a partner, then these are my children, by the way, so they have to have somebody with them. That's where support system is important. If you're doing treatment and you're going to be sick, either by side effects or treatment itself, then you want to make sure that you put that support in place. And as the doctors, the treating physicians, everybody in the team, how will that affect my day-to-day living as I am a mother, as I am a father, or as I have somebody else that I'm taking care of? And also, like I said, are you single and you don't have any family members? Some people are homeless or they don't have any family members. You have to take that in consideration so that you plan and you match your treatment to your social situation. If you have a pet, so I have many patients with pets, and they're single, they don't have a lot of people, sometimes complications arise, and the pet is left alone. So we need to know all this information, because when you get into the hospital, the palliative care team has your whole history and your whole background, and we know for sure if you're sick, then there's a pet at home that needs to be taken care of, and also for you to make plans for the pet, if anything were to happen to you. The next slide is going to touch on common myths. A lot of people think that once palliative care is involved, they take over the role of the primary team. That's definitely a myth. We don't like to work alone. We like to work as a team, and we're mostly a support. Reality is that we will work with you to help problem solve and achieve the optimal care outcomes, okay? And we do not take over the primary team. A myth also is palliative care is going to stop all life-saving treatment. No, palliative care seeks to use life-sustaining treatment when they match the patient's defined goals of care, and then the benefit versus burden. This is discussed with the patient, and we help the patient with their decisions. So if the patient wants all life-saving treatment, then this is what we support and we help them achieve. We discuss benefit burden, but if the patient wants to keep on going, then we support that. If the patient wants to stop treatment, we respect that as well, and we help the medical providers and everybody around know that this is the patient's wishes. We will be advocate, and then we will stop treatment and transition you to the next level of care. These are the common situation that you may ask yourself, especially in the inpatient area. You may when do we call palliative care? Well, if the patient or the physician say, well, we have a lot of conflicts around goals, treatment, and or nutrition. So we are presented with medical decision to be made, but the patient has one opinion, the family has another opinion, the physician has an opinion. So what palliative care will say is that we will help mediate conflicts around complex provider-patient family dynamics. And if we have CPR request and the team or the family or the patient thinks differently about CPR or life-sustaining measures, if let's say the family wants to do everything, but sometimes we don't know what everything will entails to, then palliative care helps manage difficult conversation and help understand what CPR would be at certain part of the disease. We help difficult symptoms. We also help with complex discharge needs. Sometimes the patient is very weak, but he wants to go home, but home is not necessarily where it's safe right now, and the patient needs rehab. Then we help him understand, what would be good, but if he still wants to go home, then we find resources. And then if the physician or the patient said, well, I didn't have enough time, or it's emotionally difficult and time consuming to talk about different options, then palliative care, we have the time that most of the specialists don't have to sit down with you and go over the emotions and also answer all your questions. We have your time to sit with you. And that was my presentation today around palliative care, going over what does palliative care do, what is our scope of practice, how we can help you, what is quality of life, how to match your quality of life with treatment plans, and the different questions around advanced care planning, around the myths and what we know in the community about palliative care. So thank you, everyone, for listening, and thank you to the Colon Cancer Alliance for inviting me.
Well, thank you, Dr. Joseph. That was excellent information, and we now have some time for some written questions. Our webinars are always intended to be interactive if we have time remaining, and we do this evening, so we'll be taking your written questions electronically. To submit a question, please click on the small plus sign located next to the word questions on the right side of your screen up in that control panel that you have on your at your computer at home. type your question and then hit enter. And if we are unable to get your question tonight, we'll respond to you by email. Okay, a couple questions here real quick, Dr. Joseph. Is palliative care covered by insurance?
Yes, it is covered by insurance, by most insurance company, and some insurance companies have a package actually for palliative care where you can get so much support and a lot of care related to palliative care and symptom management. Yes, it is covered.
Okay, and what would be your recommendation to someone who doesn't have palliative care currently with their primary course of treatment, and they want to talk to their doctor? How do you talk to your doctor about getting palliative care?
Yes, it's very important. Most likely, you would go to the clinic, to the office, or you can call even if you don't have a scheduled appointment and ask the doctor about palliative care services. What I would recommend is to mainly say the different reasons that we talked about why you need palliative care. If it's for pain management, for emotional support, because there's still education to be done and certain providers still see palliative care as hospice. So if you ask for palliative care, it's usually helpful to tell them why, because they may think that you're referring to hospice and they say, no, you don't need palliative care. But always advocate and educate at all time and ask for palliative care services if it's available in your area. That's what I would recommend, to really tell them exactly why and explain to them the definition of palliative care so that they can they can refer you to the services. Yes.
Okay, have a question here. It's do you think that perhaps palliative care should be renamed to supportive care? In that historical meaning of palliative really does not apply any longer to what is really the more modern supportive care. What are your thoughts on supportive care versus palliative care, and or is this just semantics?
I think it's a great idea because you do have semantic issues around it, with the name, the confusion with hospice. And around the country, most cancer centers have supportive care instead of palliative care to their palliative care centers. So you would go there and see, oh, this is the supportive care. It's really a palliative care program, but we felt that patients were more accepting of palliative care if it was called supportive care. On a palliative care professional standpoint, I've never had a problem with my patients because once I talk to them and I introduce the concept of palliative care, they understand it. They do not have any problem with the terminology. It's really for people who don't understand the scope of practice, but then you want to encourage them to come and not be afraid that it is about death and dying. Then I agree supportive care has been shown to help with that misconception. And I agree with others that defend that this is palliative care. With education, we will be able to make everybody comfortable with getting palliative care.
Excellent. What is palliative care's role when patients present in the ER with life-threatening chemotoxicity, for example? Is there a protocol criteria for palliative care consults in the ER?
There is in some facilities. Remember, we were looking at the nation's map, and so there are areas that have less robust palliative care programs, but where there is strong, robust palliative care program, it is involved from the emergency room to the oncology service to the ICU to the regular floors. And there's protocol in place that are very known, such as, for example, the IPAL-ER, which has been developed so that we can implement palliative care and have a structured protocol. Some ERs have palliative care social workers only available, not necessarily a physician or a nurse practitioner, but also what the social worker would do is triage. And if it's chemotoxicity symptoms, they definitely need a palliative care doctor to manage the symptom. Then that social worker will call a palliative care physician. So it is, some hospitals have it, some don't, but the high robust palliative care program centers and hospitals have palliative care from the ER. And it can be also for acute pain or intractable pain, secondary to cancer, then palliative care is definitely indicated. Two things can happen. Either you're admitted into the hospital and get palliative care pain management in the hospital, or your pain is managed in the ER and you get referred to outpatient palliative care.
Okay. Going back to the insurance questions here, for insurance purposes, if one is seeking palliative care for emotional support, does this differ, or is it different than asking a therapist with a psychologist? Is there a difference for emotional support and a therapist?
Even in therapy, well, the palliative care program, usually it's multidisciplinary, and they have a social worker involved, part of the team. The therapist also can help with that. We have oncology counselors. I work with a very good oncology counselor here. That is specific to cancer. I think, you have to know what's the scope of practice, because some therapists are good at certain things. Let's say addiction, or, every therapist has their specialty. But dealing with serious illness, it's a different skill. But I think that any type of emotional support you can get, a therapist or a social worker will be able to provide that. And as far as palliative care, even the physician like me, we are trained in communication, the social worker, the spiritual chaplain, it will be covered by insurance, and we have at least some counseling or serious illness counseling training to help you through the emotions. So we all in the team have the skill and we can all help. But if you don't have palliative care but you have access to a therapist, I think that's going to help as well. And if that doesn't work or your needs are not met, always ask for a second opinion or alternative care.
Excellent. Have a question here from an attendee. Can chemo be used as palliative care for stage 4 colon cancer patients? Smaller doses or on an irregular basis?
Yes, there is what we call palliative chemo. The reason why it's called palliative chemo is usually the cancer is very advanced, so we know that the chemo is not going to cure for the patient to be cancer free, but it may be able to slow down the progression. It may be able to help with symptoms, for example, of obstruction or pain, or tumor burden. So palliative chemo is very useful for the right patient that has the right functional status, and there is different protocol out there that it is indicated. It can be in lower doses. It can be just the combination of the chemotherapy drugs that is considered palliative chemotherapy. It's usually for patients who have advanced cancer. It's called palliative because it will not cure. It will help with quality of life or help with symptoms, or sometimes people want to just try what is available. But it's important to be doing palliative care that when it is introduced, that we know it's palliative chemo, that we have the understanding that it will not cure the cancer, that it is still life-threatening and it's still serious, and it's just going to slow down the process.
And a closely related follow-on question, since there appears to be palliative chemotherapy, is there such a thing as palliative immunotherapy?
Not that I know, actually. um, Not it. I don't know if it's called palliative immunotherapy, but immunotherapy actually is revolutionary. The outcome, the data out there are very good. I can say it is a form of palliative treatment in a way that it may not cure the disease, but it is providing relief or actually extending the patient's life. There's great data out there, and that's actually one of the things that I'm very excited about. Uh, I- I've not heard of palliative immunotherapy. I'm not sure if it's a recent terminology, but immunotherapy in itself can be palliative,
Right.
meaning, yeah.
Yeah, immunotherapy is so new, and they're making such advances for, especially the microsatellite instability realm. It's so new in the immunotherapy realm that they're still learning more. There's quite a bit we don't know. So as that changes and that Pandora's box opens, the question of does palliative immunotherapy exist will probably manifest itself over time. But right now, I think it's a little too early.
Yes.
The What happens, or what do you recommend if a clinic or a practice does not offer palliative care?
I would say do some research. There are website sites out there that are very patient friendly or professional friendly they have directories. So you may belong to a system that does not have palliative care, but either your hospice agencies, and that's what sometimes people are very scared. But what we have in the community now is a lot of the hospice agencies are providing palliative care. So even though their name is, let's say, hospice of this, but they do have a section for palliative care. So I would recommend doing some research, especially with the hospice agencies, and ask them if they are providing palliative care through that same agency. And it's not hospice, it will be palliative care. Or if you belong to one system, you may want to call another system in the area and ask if they have palliative care services. Your provider may not offer it, but it will be there in the community for you, and they will probably need authorization to see you. So that provider, even though if they don't provide it themselves, they can refer you or agree for these services to be implemented for you.
Okay. Well, hang on here. There we go. I want to thank everyone for your questions this evening. As always, we surely do appreciate them because many times we find that there are multiple attendees that have the same question, and the question and answer component is something that we find very valuable, and the attendees really appreciate it. So thank everybody for their questions here. As a reminder, all of you will receive a follow-up email tomorrow about this time with a link to a very short feedback survey. It's the same email that's going to have the link to the online where we post the recording online. We value your opinion, and I promise it will only take a minute or two, and I appreciate hearing back from you on how we could do things better, and we appreciate your feedback in advance. But please join us next month when we have a clinical trial webinar. That'll be on Tuesday, April 18th. Our April webinar will be all about clinical trials and our new exciting clinical trials finder that we will make it easier to have folks match their diagnosis with trials as well as connect with other patients who have gone through or are going through a study. Join us as we learn what the different phases of clinical trials are, as well as how to use this new tool and make the most of the clinical trial database that we have. Registrations will be opening soon. Please stay tuned to our newsletters and our emails and our social media resources, or visit our website, ccalliance.org, in the news and webinar area located in the Get Information section in the coming weeks. Lastly, if you have any questions or financial support related or treatment or if you need that buddy, or if you just want to talk, or in a personal one-on-one setting, you can always speak directly with one of our certified patient and family support navigators who staff our helpline at 877-422-2030. And you can also visit them online for a live chat at ccalliance.org. I would like to thank our presenter for this evening, Dr. Joseph. We appreciate your expertise and your experience providing comfort and peace of mind to our patient community. Do you have any last parting thoughts for the group, Dr. Joseph?
No, I just want to thank them again and definitely hope that the information will help increase access to palliative care. You're your own advocate, so that care is very supportive, so make sure that you ask about it.
Excellent. Thank you very much again. I think you had a great presentation this evening and lots of awesome information. Before I go, I'd like to thank Lilly Oncology for their support in making this educational webinar possible. And as a reminder, the webinar was recorded, and you'll get that link tomorrow about this time. That link will take you to our YouTube place where we post our webinars, and that's where you can access the recording. If you have any questions regarding the webinar, you can always email me at kbergerson@ccalliance.org. On behalf of the entire Colon Cancer Alliance team, thank you for attending this evening. I hope you found it informative and value added. Have a good night and take care, everyone.